Good morning. My name is Rondi. I'm a second year student in Southwestern University. I'd like to know your name, please, and how old you are.
My name is 5. My age is 18.
18. Okay, thank you. So I'm going to ask you to remove your clothes and do inspection on you. Is that okay?
Yes.
Patient here, he will be inclined at a 30-degree angle. So we're going to proceed with identifying the JVP. Normally, it is right behind the sternocleidomastoid here. You'll be able to appreciate it as much as the external jugular vein, which runs just outside, and you can see that very clearly here in this patient. Also, you'll be able to see some pulsations here from the carotid. And I'd like you to go ahead and look at that right for me. I'm going to start with identifying the JVP, checking for its elevation using a ruler and a straight edge. Any straight edge will do. I'm going to start at the suprasternal notch here and measure 3 to 4 centimeters to see if it's normal. If it's below, then it's fine. If it's above, then you have ventricular hypertrophy, maybe a possibility in this patient. So we're going to start here, and we're going to identify. Go ahead and turn all the way there. There we go. And then start here. And I'm going to identify the highest point and make sure that it is parallel. So again, just below 3 centimeters, so it's normal. Next is where we're going to go over the cardiac. First and foremost is we're going to do the inspection of his upper torso and see if there's any pulsations, lesions, scarring, anything unusual that we may be able to spot. And we're going to need to use tangential lighting just to kind of observe anything unusual. Looks like everything is normal. We're going to auscultate the sternal angle of Lewis. Walk your fingers down to the right sternal border in the second intercostal space. That's your aortic area. Go to the left. And then from there, you have a third intercostal space, or Erb's point. And fourth. And fifth. For the right ventricular area, and then afterwards for the apex. I'm going to do it again using the bell. There were no bruits or murmurs that I heard of, or anything unusual, any extra sounds, like an S2 split. I did not hear any S3 or S4. We're going to do the lateral decubitus maneuver to check for any mitral stenosis at the apex. Right here. Go ahead and turn. All right, now I need you to breathe in and then breathe out and then hold. Ready? And go. Okay, thank you very much. We're going to perform the, have him sit up and lean forward so that we can check for aortic regurgitation. So go ahead and lean forward, sit up and lean forward for me. And go ahead and breathe in and breathe out and hold. Okay, thank you very much. Next we're going to do palpation. We're checking for thrills. So, and then also, we're going to do check for heaves or lifts. Point of maximum impulse is just at the apex, fifth intercostal space, mid-clavicular line. His PMI is normal. Any displacement would suggest that there is something wrong cardiovascularly. So we're going to check for the peripherals for the cardiovascular system. First thing I like to do is obviously inspect, check and see if there's anything unusual, scarring, or anything of that sort, including the feet. Okay. After inspection, we're going to double check and see if there's temperature changes. Hands, legs. next we're going to check for radial pulse. Checking both sides for any radial unusuality. They're both normal for me. Get your hands out like this. I can see if there's any cyanosis, signs of tarring, split hemorrhaging, any of that sort of thing. Hands up like that. I'm going to check for capillary refill time. I'm going to squeeze his finger here for a few seconds, and then less than 2 seconds is normal for filling. Yep, looks like everything's good there. I'm also going to proceed with the Allen test. I'm going to ask you to squeeze it about 10 times, 8 to 10 times, and then afterwards you're going to squeeze, and then I'm going to block both your radial and ulnar arteries, and then I'm going to let go of one. And squeeze.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, squeeze.
And open up. Very good.
Do it again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
And open up. Good. Colors return immediately, which means that he shows signs of good circulation. I'm going to check his other side as well.
Same thing. 2, 3, 4, 5, 6, 7, 8, 9, 10, squeeze.
Good. Do it again, one more time. Squeeze. There we go. Very good. Okay, looks like everything is normal in his Allen test. Okay, I'm going to check for edema. It's normal. So next we're going to check for pulses, popliteal, just right behind here, and the popliteal fossa. So we're going to proceed. I'm going to have the patient lift a little bit so that I can feel for the popliteal pulse. Okay, it's there. Next, dorsalis pedis, again. Check on the other side as well. Very good. Next. Definitely feel that there. Behind the medial malleolus is the posterior tibial pulse, which I'll be checking right now. Very good. All right. Thank you, sir. I think everything is done. Also, to identify the grading pulses for the peripheral areas, 3+ is bounding, 2+ is normal, or rather brisk, and it's normally 2+, and also 1 is diminished, and 0 means that there's no pulse or it's missing. Upon examining Ephraim, 18 years old, in inspection, I did not see anything unusual, or scarring, cyanosis, any of that sort of thing. Upon auscultation, the sounds of his heart were normal. S1, S2 was normal. There was no S2 split. There was no S3 or S4 or any other extra sounds. Also, his JVP and his carotid pulsations were also normal. And upon palpation, his PMI was in the correct position. There were no heaves, thrills, or murmurs. His extremities were normal. I didn't find any edema. They were warm, palpable. There were no tenderness. There were no bruise. His vasculature was fine. There was no stasis changes. And also, upon checking his pulses, his radial and brachial, they were normal. Also, his popliteal, his dorsal pedis, and his posterior tibial were also normal. This was a normal cardiovascular and peripheral exam.